Good morning. Do we think we have enough people in here to get going? Last few stragglers trickling in. All right. Morning, everybody. Um, y'all know me. I'm Jessica Zvara. I'm part of the TCV group, and we are going to talk about alpha-gal today. So I have no financial disclosures to list, unfortunately. Um, Quick review of goals of the talk today. We're going to talk about alpha-gal syndrome, history, physiology, epidemiology, how it affects us as anesthesiologists in the operating room, review the current best evidence for practice, and then discuss future research opportunities and growth opportunities in the field. So to start, what is alpha-gal? We're fortunate here in little Charlottesville. Fortunate might be a strong word, that we know a fair bit about alpha-gal. I think most of you have probably seen it at some point in your career so far. For a lot of the country and the rest of the world, it's not so prevalent and so less common. So when I was putting this talk together or working on a paper, this is a couple years ago now, I was texting with, let's call him a mentor of mine in the field, a senior anesthesiologist who's been in this for a long time, well-published, well-known, about alpha-gal. And this anesthesiologist, AKA my father, texted me back, "What is alpha-gal? You mean women in cardiac anesthesia, boss girls, challenges, rewards, career paths, etc.?" You can see my response there. And fortunately, he has a good sense of humor. I know a lot of y'all know him. He okay boomered himself. And then I promised that if I ever gave a talk on this, I would encourage everyone to laugh at him. Just a little, laugh with him, I should say. So that being said, alpha-gal has been permeating the news a little bit more, especially this last year. Y'all might have seen the headlines. There was the first death directly linked to alpha-gal. I think it was back in the fall for the pilot who didn't know he had the disease, ate a hamburger, went into anaphylactic shock and died. So as it continues to kind of permeate the national knowledge, we will continue to receive more questions and need to have a little bit more of a basic understanding about what alpha-gal is. So what is alpha-gal? Well, it's a syndrome. It's an allergy to an oligosaccharide called galactose alpha 1,3 galactose. You can say that 5 times fast and realize why we call it alpha-gal. This oligosaccharide, which, reminder, that just means small sugar, is widely expressed in non-primate mammals. And this allergy is primarily mediated by IgE. So quick refresher course, IgE-mediated allergies, it's a type 1 hypersensitivity. So B cells are stimulated to produce IgE antibodies specific to an antigen. That IgE binds to mast cells and basophils, sensitizing them to that antigen. Then when exposed to the allergen, all of those sensitized cells degranulate, releasing histamine, leukotrienes, prostaglandins, all that yucky stuff that ultimately ends up in your classic allergic symptoms. So just a quick second, grab your coffees, take a sip. I'm gonna have a sip of water. I think the story of alpha-gal is really interesting. It actually starts a long time ago, back in 1936. Anyone know who Carl Landsteiner is? Yeah, father of ABO grouping, one of the original scientists who did a lot of the original work in blood typing. He showed that the serum of humans and some higher primates contained antibodies to a B-like antigen. So like type B blood, a B-like antigen present on non-primate mammalian cells. That antigen was eventually down the line linked to the alpha-gal epitope. Further study showed that all humans have abundant amounts, tons of IgM, IgG, and IgA antibodies to alpha-gal, but specifically not IgE. So thinking kind of broadly, that continues to have ongoing importance with xenotransplantation, thinking about putting pig hearts in people or pig kidneys or whatever non-human organ, because all people have all of these antibodies to alpha-gal, IgG, IgM. It's hard to immunosuppress them. So fast forward a handful of years, And a small case series was presented to the Georgia Allergy Society, demonstrating this new onset meat allergy after a tick bite in 5 people. Sounds vaguely familiar. It was submitted to the CDC with hope for further study, more nationally at a larger scale. Nothing happened. They slept on it for years. Now 2004. Cetuximab, which you all now know is a very commonly used monoclonal antibody in cancer, so specifically for colorectal cancers and head and neck cancers, was developed. Early in the studies, investigators noted a rare risk of rapid anaphylaxis to the medication, where patients would come for their infusions and immediately devolve into anaphylactic shock. Interestingly, as they were doing this initial phase 3, these large studies looking for these interesting signals, it seemed to occur more frequently in the southeastern states, specifically North Carolina, Virginia, Tennessee. They started gathering more data and publishing. This one came out, I think is ultimately published in 2007, where they directly linked that it was really locally isolated to these regions. Concurrently, this just undercuts the importance of basic science and everything that's going on. A basic scientist identified that alpha-gal was the relevant epitope in the cetuximab population. It was located on the Fab domain. Remember your monoclonal antibodies. And then they were able to say specifically this alpha-galactose sugar was the problem with cetuximab. And they were able to publish in the New England Journal, saying that some people had this specific IgE that induced this anaphylaxis in folks getting cetuximab. This is where it gets interesting. During the same time, the same group of researchers began seeing patients with unexplained urticaria, angioedema, unexplained anaphylaxis. And these are researchers mostly based in those southeastern states. As they did their due diligence, taking thorough histories of these folks, they found some common characteristics. A lot of them were very outdoorsy type people, did a lot of hiking, farming, that kind of thing. Some had a history of eating meat 3 to 5 hours earlier. And this is where I think it gets really cool, where it's just really good luck on top of amazing science. When they put all of their case data together, they started just throwing the kitchen sink at these people, where they just tested them for all sorts of antibodies that we had, including this newly discovered antibody for alpha-gal. And what they found is that in these patients, these are the cardinal cases that they found, you can see that their total IgE is markedly elevated. And my little red circle covered the SIgE, the specific IgE for alpha-gal was also markedly elevated in this population. And you can see in these patients, their reactions listed on the far side of this slide. Some of them were relatively benign, hives after eating pork, hives after eating lamb chops. Some were pretty profound, full-on anaphylaxis, anaphylactic shock with a pressure of 40 over 0, requiring hospitalization, pretty significant reactions. And so that same group who had access to the cetuximab-specific alpha-gal IgE were able to take that information, start to test these other patients with that antibody, and they're able to link consumption of red meat in patients with these antibodies to alpha-gal with delayed anaphylaxis. Now, the data came together in 2008, it was ultimately published in 2009. Interestingly, when I was pulling all the data for the different papers for this, I found a poster presentation from Australia in 2007, so just a year or two before, that seemed to find a similar link. Different tick, sort of different scenario, but it's around this time where the world seemed to be starting to realize that IgE and to alpha-gal and a meat allergy were somehow linked. Fast forward a few more years, they took that information on these patients being very outdoorsy, and they were able to specifically link exposure to a tick bite to production of these antibodies in these patients to alpha-gal. So this is from that paper. You can see on your right-hand side of the screen, these are 3 different patients with time on the x-axis and levels of IgE on the y. The blue is total IgE levels. The black is alpha-gal IgE levels. The red arrows are tick bites that are known tick bites, and the stars are when they developed allergic type symptoms. So taking it one patient at a time, you can see on the very top there, total IgE levels spiked after an exposure to a tick bite, including your alpha-gal IgE levels. And then you can see where the patient developed symptoms. Interestingly, on that top patient, you can see how after an initial drop in the antibodies, a third tick bite, a third exposure, and the levels shot up again. Similar patterns in the other two patients, where exposures to tick bites led to a marked increase in the IgE levels, and then a secondary exposure led to recrudescence of those levels. Really, you see it down on the third one, where after that second tick bite, skyrocketed the levels, and then they had their anaphylactic type reaction. The bar chart on the side, it shows you your overall titers to IgE. And so you can see in people who have no tick bites, their titers are very low. And tick bites with a short-term reaction, less than a couple weeks, you have moderate level titers to alpha-gal. But in folks who have longer-term reactions to tick bites, their titers really get a lot higher. So they're able to definitively show there is something to the exposure of a tick bite to increasing your IgE levels. So I just think it's interesting how luck, science all came together to really help us understand alpha-gal as an etiology. So 15 years later, what do we actually know about alpha-gal? Well, it's this little sucker here, the Lone Star tick. HIPAA aside, raise your hand if you've been bitten by a Lone Star tick. That's a big chunk of the audience, myself included. Also known as Ambuloma americanum, alpha-gal is actually found in the saliva of ticks. So we think that somehow that bite of the tick injects a little bit of that alpha-gal epitope through the saliva into a person's skin, and that triggers the allergic response. We've established that this particular tick appears to be the primary culprit in the US, and what's super annoying is that it's not just adult ticks. Nymphs and larvae are also known to bite humans, and they can trigger alpha-gal, which makes this very different from other tick-related diseases. For example, Lyme disease, nymph bites, larva bites will not transmit Lyme disease. So super rude. As you all know, probably the distribution of the Lone Star tick, this is where we are from the CDC in 2024. The red is where it meets criteria for an established population. The yellow is where we're pretty sure they are. It's the entire Southeast, including up into the Midwest. It's rising now up into the Northeast. We are one of these little red spots in the middle of Virginia. We know the population is growing and expanding. It used to be more contained to the Southeast, but over the last 10 years, it's really skyrocketed in all the directions. A lot of reasons for that. Climate change, human encroachment into more densely wooded areas, but most importantly, my nemesis, these guys, the white-tailed deer. For all of those reasons, as we continue to have more deer cohabiting with humans, we are going to have a continued progression of Lone Star ticks because these are their hosts. So what does the life cycle look like? So like I said, the tick usually feeds off the white-tailed deer. Ignore the cute fawn. I don't know why they used a cute fawn. I hate these deer. So they live off the deer. Then they go from the grass to the deer, back to the grass. And then as you go for your nice walk on a sunny spring day out in the mountains, you walk through some tall grass, you get a couple tick bites on your legs, whether they're larvae, nymphs, or adults. And if you're unlucky, what happens is you start to develop that IgE specific to alpha-gal. You can see over a course of weeks in the top right corner that alpha-gal is slowly going to rise until at some point, some tipping point, you get exposed to the allergen, specifically that alpha-gal oligosaccharide in non-primate meat, so beef, pork, lamb, any of those. And then 3 to 5 hours after the meal, you develop your allergic type symptoms. The classic symptoms are fairly interesting because they have a wide spectrum of presentation. It can be just isolated GI symptoms, nausea, vomiting, diarrhea. It could be classic, more like hives, itching. It can be more severe angioedema, all the way up to anaphylaxis. What's interesting, there's common things that make sense that'll increase the risk of reaction. Higher alpha-gal IgE, or just higher relative IgE as a ratio of your specific IgE to your total IgE. What's super weird is that there's certain cofactors that increase your risk to having a reaction: alcohol, exercise, and NSAIDs. I don't know why. But so for folks who have alpha-gal, they're more likely to react if they have a burger with their beer and expose themselves to alcohol. Out of the allergy literature, what's interesting is that the diagnosis is consistently inconsistent. That's one of the hallmarks that they find for actually hammering down a diagnosis of this. A lot of people, it can be isolated just to the GI tract. And what's interesting from this article I pulled is that they make a point to say that a lot of these patients can be delayed to diagnosis because they get misdiagnosed over the years as having a food allergy or having inflammatory bowel syndrome or irritable bowel syndrome or something else causing diarrhea, nausea, until finally they end up seeing a true allergist who gets them diagnosed with this. And they make a point about the cofactor dependence, where some people won't have a reaction unless they get exposed to exercise or alcohol or NSAIDs. And they also comment that a lot of times, because there's this delay in the presentation of 4, 5, 6 hours, it might be after you go to bed. And they said, don't underestimate how many people take Benadryl to help them sleep at nighttime and then are thereby masking their symptoms for a long time. What's super interesting to me is that unlike most food allergies, classically, alpha-gal is an allergy is delayed 2 to 6 hours. Why is there a 2 to 6 hour delay? Nobody really knows. There's a bunch of theories floating out there, but no one's actually hammered down why specifically alpha-gal has this hours-long delay. This is one theory that recently came out in the 2024 literature that I find fairly compelling. And the idea is that, so you eat your burger, it goes to your stomach, all of those fats are emulsified in your intestines, they're repackaged as chylomicrons, they get reabsorbed into your thoracic duct. That takes about an hour. It takes a couple hours to get up to where in your thoracic duct where you can get reabsorbed into your systemic circulation, gets across the blood barrier where it gets repackaged into your VLDL and your LDL, and only then, about 4, 5, 6 hours later, when it's in the LDL or VLDL form inside the bloodstream, then it's exposed to your immune system, and you can get kicked up into higher gear and get that allergen epitope reaction started. Is this true? I don't know, but this is a good theory from smart allergists, and it makes sense to me. So diagnosis and management is very simple. Diagnosis, you get titers, blood tests. A lot of allergists will still do skin testing. They love doing skin testing. They can use beef, pork, or milk extracts. Although, interestingly, commercial prick extracts or prick tests may be limited, and they have to do fresh meat testing, which is kind of icky. And then using really thorough food diaries where they make you write everything you ate, your exposures, your symptoms, and track that over time. Management's fairly simple. Easy for me to say I don't have alpha-gal, but you avoid the triggers. For some, that their reaction may be so severe they actually have to avoid dairy altogether. For many, symptoms will get better over time. But remembering the data that we saw, their symptoms may recrudesce again with repeat tick bites. And it's important just to comment, a lot of my information in our conversation is focused on the United States, but this is a worldwide phenomenon. There's been documented alpha-gal in every country highlighted on that map. It's different tick species in other parts of the world. I'm not going to pretend to say the Latin names, but in the back of your head, we just have to remember that this is not an American problem. It's a worldwide problem. And just as a caveat, there's a real bias, I think, in the data that we have where you can see it's really like Western countries that have been reported as having data. That doesn't mean that there's not alpha-gal in the countries that are not represented on this map. So all that being said, what does it mean for us in anesthesia? We don't want our patients to be eating hamburgers. We don't want them to be eating steak before they see us. So how does it affect our day-to-day? This was a lovely review a couple years back out of ANA, where a group of anesthesiologists sat down with their pharmacy and they went medication by medication and talked about any risky drugs that may have some component of animal derivation in it. There's a lot of like double negatives, maybe, if then here. So it's not, this medication definitely has this animal product in it. But what they saw, anything that's stearic acid, lactic acid, stearate, glycerin, gelatin, theoretically could potentially have a little bit of contamination where that when it gets repackaged into drug form may possibly increase the risk of exposure to the patient. I'll say though, I give all of these drugs to my patients with alpha-gal and I've never had a problem with them. Any poll of the back audience, no one's ever had trouble with these medications. It's just important to keep in the back of your mind with, as you're managing your patient with alpha-gal, just to check yourself and think through the medications you're going to expose them to and make sure you are being thoughtful. More importantly, for 100 points, who can name this drug? I'll give you a hint. I'm a cardiac anesthesiologist. Heparin. Okay, so that's what heparin looks like. And that's what we're going to talk about for a chunk of time, because pharmaceutical heparin is directly derived from porcine and bovine sources. So while there's no intrinsic alpha-gal in heparin, it can theoretically be contaminated due to its source. And that risk of contamination appears to be higher than all those other drugs that I talked about, where it was a lot of more if-thens. Different heparin lots can theoretically contain different amounts of alpha-gal, just depending on how much of that contamination exists in the manufacturing process. And again, theoretically, the higher the dose, the increased risk and reaction. So where do we use heparin? Well, I use it all the time. We all use it all the time. EP uses it all the time. If you do anything with mechanical circulatory support, we use it all the time. But how often do you give sub-Q heparin for DVT prophylaxis? Pretty much daily, right? So it affects all of us in our management and our practice. So how can it look for us in the operating room? And I'm going to break this up into cardiac and non-cardiac, again, acknowledging my bias of being a cardiac anesthesiologist, but we just use higher doses more frequently. So the non-cardiac OR, well, it could just show up as a non-specific allergic reaction. It could be as benign as someone getting hives, their lips swelling a little bit, or straight up to anaphylaxis. So just as a reminder, if you have a patient who develops anaphylaxis in your operating room, just keep alpha-gal in the back of your head. There's nothing to do in the moment other than doing your crisis resource management of managing the problem in front of you, which is anaphylaxis. But then as you transition that care out of the operating room, consider that in the back of your mind as you hand over care to an allergist, a medicine team, an ICU team. So for us, most of our information in the heart room is based on case reports and case series, which makes this kind of hard because we don't have a lot of data. There's been a couple nice case series. This is one that was published about 10 years ago at 3 patients. One had a mitral, one had an aortic, one had an aortic valve and an ascending aorta. One patient got just urticaria on post-op day 1 that got better with some H1 and H2 blockers. One patient developed at the end of the operation, whatever that means, a total body rash, wheezing, hypoxemia that got better with some epi, Decadron, Pepcid, and some fluids, so kind of that classic allergic management. The last one's kind of interesting because the central line is flushed with heparin, just low dose, and immediate hypotension, rash, and angioedema, floored anaphylaxis immediately. They treated with the normal stuff and the patient got better. There's another case series of 4 patients, 3 of whom had known alpha-gal. One was an AVR with known alpha-gal. They had no issues. They did pre-treat the patient with some steroids, some Benadryl, and then so like oral stuff beforehand. On the day of surgery, got high-dose steroids and Benadryl, did fine. The next one is a CABG who had known AGS. Again, no issues. What they did was a pre-op test dose. They didn't specifically specify what that was. They used the same lot of heparin intra-op and then gave some steroids before the heparin with no trouble. The third one, they didn't know about the AGS. So they had an uncomplicated intra-op course. At the end of the surgery, the drapes down. They noticed a total body rash that got worse on arrival to the unit. Immediately got some methylpred and a little bit of Benadryl. It was maintained on low-dose epi. Interestingly, same day, developed ST elevations, rushed to the cath lab, and was found to have acute thrombus distal to their lima to LAD anastomosis, where they just did an angioplasty with good results. The thrombus surgical? Was the thrombus from the alpha gal reaction? I don't know. It's just interesting. The last one is a cabbage with known AGS who got rash and maybe some vasodilation, pre-treated with steroids and Benadryl, mild rash at the end of the operation, but was profoundly vasodilated, requiring large resuscitation, but got better in a day. Was it AGS, which is the ACE inhibitor they had taken pre-op? Who knows? So I mentioned earlier there was a 2 to 6 hour delay in oral consumption and oral exposure to these meat products. And as you saw in those case reports, there can be a wide variability in the timing of the presentation of your allergic symptoms in the operating room, which makes it really hard and really challenging. It can be immediate, like that guy who got heparin in a central line and just went into anaphylaxis. It can be somewhat delayed, presenting as maybe some vasoplegia on bypass. Or it could be post-bypass into the early post-operative course, where it could be, is it vasoplegia? Are we bleeding? Are we hypotensive for some other reason? Or is this just simmering alpha-gal in the background that we're not managing? Here's my anecdata. So I did a straightforwardly minimally invasive MVR. We were extubating. As we were extubating, we got more hypotensive. We were wheezing. When we got the drapes down, total body rash, just floored rash. So we immediately went down the allergic pathway. Epi, hydrocort, Benadryl, Pepsid immediately got better. So we took him upstairs to the ICU intubated. During the event, we sent a tryptase, which was positive, and then we recommended the ICU to send an IG to alpha-gal, which was also moderately elevated. The allergist said it was probably a reaction to Sagamodex about 30 to 40 minutes before, which, as you all know, Sagamodex typically has like an immediate anaphylactic response. So I don't know. They're allergists. They know more about this than I do, but I just find that kind of interesting. The wife said, yeah, he gets an upset stomach when he eats hamburgers. So was it the alpha-gal? Was it the Sagamodex? It's hard to pick apart. We do have a little bit of data to support our decision-making. There's only been one large retrospective look at alpha-gal patients for cardiac surgery. You can see we started with 8,000 patients in this cohort. And then as we kind of narrow our population down to patients who have preoperative alpha-gal titers, we have an N of 17. So you can see the numbers we're working with. This is a very small population, which makes it challenging to study. So of those 17, 9 had a remote titer, 8 had one recently. 8 of those patients received planned prophylactic premedication for heparin with steroids and H1 and H2 blockers. 4 developed a severe reaction, 2 who got premeds, 2 who did not. So taking that, again, very small N, this group of surgeons did a little bit more digging, and they found there is maybe an association between having higher titers and having an allergic reaction. Maybe will help triage risk for patients. Interestingly, and I'll just touch on this because I think this is fascinating, there's also a concern for these patients for having early prosthesis degeneration. So for their bioprosthetic valves, which again come from bovine or porcine origin, whether or not having alpha-gal contributes to them falling apart sooner. Again, just a case series, it's 2 patients. One had an AVR in 2004, got alpha-gal 7 years later, and then within 3 years had severe AI and profound shortness of breath requiring reoperation. You can say 10 years is a pretty good time for a bioprosthetic valve. I wouldn't be too surprised by one falling apart, but I guess that it progressed very quickly in those 3 years. And case 2 is a little bit more straightforward. It had an AVR in 2009, got alpha-gal 5 years later, and within 6 months, doubled the gradient across his valve, which 35 is not normal for a bioprosthetic valve, so he already had some amount of restenosis, but then to go from 35 to 70 is pretty remarkable. This is also interesting. There's some data out there that suggests that alpha-gal leads to progression of coronary disease. It's well established in the allergic literature that having kind of that inflammatory allergic type prodrome is pro-atherogenic. It increases your risk of cardiovascular disease. And so what some of our cardiology colleagues have done is they've taken that and they've looked specifically at the alpha-gal population. This is a group out of UVA who did a small study, an N of 118, where they did intravascular ultrasound during cardiac evaluation. And in those with alpha-gal, they found increased atheroma burden and increased unstable plaques. What's fascinating, it was more pronounced the younger you were when controlled for traditional risk factors. So alpha-gal alone seems to have some sort of a pro-atherosclerotic effect on patients. Similarly, a group out of Australia did a similar trial where they looked at plaque burden in those with alpha-gal versus those without. They found that alpha-gal was associated with plaque and obstructed coronary disease when controlled for age, sex, normal risk factors, with an odds ratio of 1.6 for plaque and 2 for CAD. They found the rate of alpha-gal 2.2 higher in STEMI patients compared with matched stable patients with CAD. And when matched with healthy controls, the alpha-gal rate was 12 times higher in those who had STEMI. So something is there with alpha-gal predisposing folks to having progressive coronary disease. So what do we do? What are our guidelines for managing the patients when they come to the operating room? Well, we don't have any guidelines. It's really hard because the N is so small. This is such a novel disease that we're really trying to work from the limited data that we have. You can take this when you go out to practice if you're in an endemic area like Charlottesville, like Virginia, North Carolina, Tennessee. You can talk to your pharmacy and see what your exposures are. Knowing that these drugs are probably going to be safe. What about sub-Q heparin or low molecular weight heparin, something that all of you give routinely? Well, there's actually been one study looking at this, very small, done in 2022. It was a retrospective look of folks who they knew had alpha-gal. Over 57 hospital visits, they were given sub-Q heparin or Lovenox, and only one had a documented reaction to the drug. That patient got 2 doses of 5,000 units and developed papules under his eyes, which is his comment. That was that patient's reaction to alpha-gal. He would get this little rash. His titer was like modest 24. No reactions to Lovenox. So while the N is small, I find this somewhat reassuring in exposing patients with alpha-gal to sub-Q heparin and Lovenox. Lovenox in particular, because Lovenox is heparin that has been further purified, further taken down the manufacturing process. So theoretically, the risk of contamination should be even lower. So when you have to give a blood thinner, how do you choose? What do you do? Well, you can proceed to surgery or support on mechanical circulatory support utilizing an alternative strategy like bivalirudin or agatropin, which are both direct thrombin inhibitors. Pro, you just avoid the exposure of heparin altogether. You just take it out of the equation. So if they have alpha-gal, you don't give them heparin. Cons, well, you can't reverse it. We don't use it that often, so we're not as familiar. And what's most frustrating, because there's no reversal, there's a prolonged bleeding time. So I don't know about you, but raise your hands if you've been personally victimized by bivalirudin, like I have, all of my colleagues have. Bival, it is not as simple as a one-to-one switch of going heparin to bival. It is a drug that has real side effects and consequences. So for that reason, we think very carefully about whether we're going to expose our patients to heparin. So what can we do to mitigate the risk? Well, there's a couple ideas. There's this idea of heparin desensitization. It's been tested a few times in the literature with good success, where you take a patient, bring them to the hospital, maybe give them some pre-medication, maybe not, and you slowly increase a heparin exposure, utilizing heparin from the same lot with the theory that it's the same amount of contamination. Unclear if it works or if it's just good luck so far, since it's so hit or miss with alpha-gal exposure. This is basically what it looks like. This was what out of a case report in 2023, where you bring the patient in, and the first bag is like 5 units and 250. Then over time, you increase it to 50 units of heparin and 250, 500 units and 250, 5,000 and 250, and you maintain that dose of heparin until you start surgery, all through the pre-bypass period, until you give your big pump dose, and then you can shut it off. In this particular study, what they did is that after they reversed the heparin, they immediately started sub-Q heparin and continued to that through the post-operative course, theoretically keeping that patient desensitized to heparin in case they had to emergently return to the operating room for reoperation. So if we don't do desensitization, what kind of risk mitigation can we do? Well, here's this big, long, fancy protocol that we've developed here at UVA with our cardiac surgeons, looking at how to risk stratify our patients. And I'll whip through this kind of quick. So it's based on whether or not you have an alpha-gal titer. So if you don't have it, then is it urgent, emergent, or elective? If it's elective, you hold the case, you get a workup. If it's urgent, emergent, then you have to have a real conversation about whether it's worth the risk of bivalirudin versus going with heparin and pre-treating for a presumed allergic reaction. If you do have an alpha-gal titer available, it's a little bit more information. And this is based on that one study that we have that found higher titers associated with worse reactions. So if you have a low titer, less than 8 on the left-hand side of the screen, or your right-hand side of the screen, pre-medicate and go. Just go to the OR and proceed. If you're in the moderate area, well, it's an emergent versus non-emergent, whether you have time to talk to an allergist. And if you're high dose, well, you really need to hit the pause button if it's an elective case, talk to your allergist, talk to your surgeon, and come up with a plan together. Versus if it's a true emergency and you have a known titer that's very high, you need to proceed to the OR with another strategy, like bivalirudin or gatroban. What that protocol does not address at all is bioprosthetic valves, which we touched on briefly, and then bioprosthetic graft materials, bovine pericardium, which we use all the time in the cardiac room. You also use it in the vascular room, in rooms that generalists will work in. Doesn't seem to be a problem, but in the back of your mind, it's something to keep in mind. So that's our protocol. How do we actually do it? I'm not going to say we just do it live, but I'm not going to say that. Generally, most of the time, if it's mild, intermediate, unknown, most of the time we end up just pre-treating our patients with some steroids, some Benadryl, some Pepcid. Some of my colleagues, I think, do a test dose before you give your full pump dose. I typically don't because I don't know how much information it's going to give you. It seems to be fine, especially if you're pre-treated. But I think most of us will say if you have a documented severe allergy, so not someone who just gets nauseated, not someone who gets diarrhea, but someone who has full-on anaphylaxis, I think we all will firmly hit the pause button and seriously talk about doing an alternative medication strategy. And just as a reminder, smaller doses in your vascular operating rooms, the hybrid ORs for structural heart cases, EP labs, they still carry risk for reaction. So even though it's not as high as the big pump doses we give, that risk is still there. So looking forward, we need more data. We need more data. We need more data. It's so hard to study this population because not everyone has an alpha-gal level. A lot of people who have alpha-gal are asymptomatic. So it's hard to put a wide net around these patients. What's interesting is that there's good oral strategies for food allergies that have been developed for like peanuts, that kind of stuff. And they've just started testing them in alpha-gal with really good benefit. So that's maybe hope for the future. What's cool is one group has developed a knockout alpha-gal pig model. They did it specifically looking at xenotransplantation with hope to develop a heart that we can put into patients. But if we could get alpha-gal negative pigs to get our heparin from, we would obviate this as being a concern. And xenotransplantation again. So in summary, we know it's an IgE-mediated allergy to alpha-gal in meat. It's linked to tick bite, specifically the Lone Star tick. It may be associated with early degeneration and progression of CAD. Certain drugs, specifically heparin, can trigger it. And regardless of whether you work in the heart room or not, everyone should know what alpha-gal is. Everyone should know how to mitigate its effect on our population. And with further ado, thank you very much for your attention. Yes, Dr. Roach.
Sounds like you're suggesting switch from meat consumption to primate, but like, and then two, as this is from non-primates, it sounds like it'd be a good target for a vaccine, and I was wondering if there's any work on like taking a vaccine.
I'll have to defer to Secretary of Health RFK Jr. about the second question. No, I don't know. Genuinely, it's a good question. And no comment on the first part. The question for the crowd was, should we eat monkeys instead of pigs? And is there a vaccine? All right, Sunny. Yeah.
Go ahead and get medical legally, right? If they have a alpha-gal allergy and they're like, well, it's low risk, give it so they develop a life-threatening allergy situation.
That's so, yes. So the question is, what do we do with DVT prophylaxis, just from like a patient care perspective and also from a medical legal perspective, because we get mixed messaging from pharmacy. And that's such a good question. There is only one study that I showed it to you, which seemed to show that reasonably safe, but not 100%. So I feel very comfortable doing Lovenox and fondaparinux in these patients. It can be hard, especially for the patients who are cancer patients who get their intrathecal morphine here, and now you can't give fondaparinux in those patients for, I forget what the ASRA requirement is, but I think it's longer. I think that given the data we have, you could be justified in giving sub-Q heparin and just be prepared to treat an allergy. I would also risk stratify your decision-making based on their symptoms. If they have mild symptoms, I feel super comfortable. If they have profound symptoms like anaphylaxis requiring an EpiPen, I'd maybe lean more towards the low molecular weights. Yeah, Dr. McNeil, John. I think it comes back in the day here because my guy that I did, we got it within the day. But I think that's unique to UVA because we are I'm not going to call us a center of excellence, but we are a niche university where we have a high concentration of this population. Yes.
Why must not people keep eating the meat and slowly develop itself? Because ultimately the ND2 can be involved in that cause the reaction. It has they have the significant kind of central enhance the immune response.
I genuinely don't know. I think we don't know a lot about alpha-gal. The fact that we don't even know how it presents the way it presents, and the fact that it's so inconsistent in how it presents, it's very challenging to pin those kinds of things down. I know a number of our allergists here are the people who discovered alpha-gal, and they're still working on it, but I don't know. All right, I think it's time for us to get to work. Thanks, everyone.